So now we're going to turn to Avik Roy, who has just recently returned from his honeymoon. Avik Roy is a senior fellow at the Manhattan Institute and the opinion editor at Forbes. He has an interesting background that includes both medicine and finance. He's a leading conservative change agent and a sought-after presidential campaign advisor. He's currently advising Senator Marco Rubio and has previously advised Rick Perry and Mitt Romney. He's the principal author of The Apothecary, the influential Forbes blog. He's a frequent commentator on numerous television news shows, and he also serves on NIHCM's advisory board. Join me in welcoming Avik Roy.
Thanks, Nancy, and let me just second what you just said there. I really enjoyed what Andrew and Pat had to say. I think it's really inspiring to see some people really focused on improving the quality of the delivery of care. It's been a really tough problem, as you all know, and it's been actually difficult to prove in many cases that health insurance improves health outcomes, and I think the great work that both of you are doing is starting to move the needle on that. I'm going to talk about a slightly different issue, which is the high price of prescription drugs. I know that this has been a concern for many of you for decades. And what I want to argue today is that I think one of the challenges with tackling the problem of the high price of branded prescription drugs has been it's been seen as an ideological or partisan issue. And what I want to argue today is that it shouldn't be, that it's actually extremely important for both parties to put their heads together and think about ways to tackle this very important problem. As I was mentioning, it's been sometimes difficult to prove that expanding coverage actually improves health, believe it or not. But what is incontrovertible is that innovation in prescription drugs does improve health. Just take the class of drugs, cholesterol-lowering drugs called statins. They've dramatically improved lifespans and improved health and reduced incidence of heart attack and other cardiovascular events at a fraction of what we spend on conventional health coverage. So the more we can do to expand pharmaceutical innovation at an affordable price will make a huge difference in both the quality and the cost and the access to quality health care that all Americans can achieve. I should make the disclosure, as Nancy mentioned, I'm advising Senator Rubio and his presidential campaign. These are my views only. Please do not associate these views with the senator. He would get very mad at me if you did that. There are two flawed theories, might not be the right word, maybe it's oversimplifications. But there are two oversimplifications that have dominated the debate about prescription drug pricing in the United States. The first is that it's all about greed. That the reason why prescription drugs are so expensive is because these for-profit drug companies are greedy and capitalists, and they're just basically exploiting the fact that we don't have price controls and other government measures to prevent profiteering for prescription drugs. And of course, the poster child for this now is Martin Shkreli from Turing Pharmaceuticals, who was recently profiled in the New York Times for increasing the price of an old drug used to treat toxoplasmosis. But here's the thing that's important to think about, is that, well, if greed is the reason why prescription drugs are so expensive, well, car companies are theoretically greedy too, right? They have a profit motive. TV companies have a profit motive. What makes them less greedy or more greedy than drug companies? Why do we not need price controls for high-definition televisions? We don't seem to need that, even though they're just as motivated by the profit motive as any other company, as any other drug company. And why is it that drug prices have gone up so much every year? Has there been an increase in greed by 14% a year? Or is it perhaps that there are other economic factors at play? This is something that's, I think, very important to understand. We've been talking a lot in the last 12 months. The reason why drug pricing has been particularly in the news over the last 12 months has been the new new treatments for hepatitis C. And you can see that dark blue band on the rightmost bar there. That's the increase in prescription drug spending last year due to new drugs, and that's mostly hepatitis C and multiple sclerosis drugs. But the light blue band is actually the really important one, which is price increases for drugs that have already been on the market. Often these drugs have been on the market for 5-10 years. And that's actually a bigger driver of what we spend on branded prescription drugs than these new innovative drugs. It's the older drugs where drug companies are choosing to charge more. The Turing Pharmaceuticals example is an egregious and exceptional one, but it's a very common practice for drug companies to raise the prices of drugs that have been on the market for many years. Now, the other theory that you hear a lot is that innovation is expensive, and that's why we have to charge what we charge in the United States for prescription drugs. And Mark Zuckerberg is laughing at that theory because, as you know, his product doesn't cost anything, at least for you to use it as a user, as someone who joins the Facebook social network. Google's search engine costs $0 to use. Those two companies don't argue that, well, I have to charge you $1,000 to use my search engine, otherwise I wouldn't be able to fund innovation. You'll never hear Google say that. You'll never hear Facebook say, no, we need to charge $1,000 a month for you to use our social network, otherwise we wouldn't be able to innovate. So why is it that pharmaceutical companies and biotechnology companies argue that high prices are necessary to fund innovation? In fact, in most sectors of the economy, it's low prices that drive innovation. Clayton Christensen, the professor at Harvard Business School, who's written a whole book about this called Disruptive Innovation, his whole point is that most innovation happens at the bottom of the price scale. When Japanese car companies came to the United States, they didn't compete in the luxury market. They competed for the most affordable cars, the Honda, Civics, right? And then, as they gained market share in those areas, they moved up the price chain. And now they make Acuras and Infinitis and Lexuses and dominate those markets too. But they first found out how to deliver a high-quality, reliable car at a low price, and then moved up the value chain. Why is it that that's not really happening as much in pharmaceuticals? Let's take another case. So I mentioned Google and Facebook before. Let's take, well, you could say, well, those are internet companies, that's software, those aren't physical products. Maybe that's somehow different. Well, what about Apple? Apple's products are not cheap, as we all know. They're premium smartphones. They cost more than the typical smartphone. How has pricing with Apple products evolved over time compared to prescription drugs? So it's hard to imagine, and it's hard to believe, actually, but the first iPhone is only 8 years ago. It was launched only 8 years ago. The iPhone 1, we can call it now, the high-end iPhone 1 had 8 gigs of memory. It had a 320 by 480 screen. Obviously, let's not get into the microprocessors. The microprocessor was slower than the ones we have today, and it cost $599 when it was first launched. The most recent premier iPhone that was launched this year is the iPhone 6s Plus. It has 128 gigs of memory, so that's 16 times the amount of memory. It has a screen that's 13 and a half times the resolution. And on an inflation-adjusted basis, it costs 27% less than the original iPhone. So I bring this up to say, when was the last time you heard of a new drug? Because we talk a lot about innovative pharmaceuticals. When was the last time you heard of a new drug that improved health outcomes by 16 times and cost 27% less than the prior standard of care? By that standard, the pharmaceutical industry has failed to deliver value and innovation in the scale that we're accustomed to seeing and actually expect from the retail technology industry. Here's an example that I stole from one of my Forbes colleagues, Peter Bach, who's also an oncologist at Memorial Sloan Kettering. And Peter here is discussing the evolution in the price of Gleevec, a truly innovative drug, which at the time it was launched in 2001 was the harbinger of this revolution that we now experience quite routinely, where we've identified a molecular target for a disease and then designed a drug that targets that molecular defect, and in the case of Gleevec, cures in many cases chronic myelogenous leukemia. The price of Gleevec, I shouldn't say today, but this year, the patent actually expired in the United States earlier this year. But at the end of its patent life, Novartis was charging more than double for Gleevec what it was charging when that drug was first launched. And that's despite the fact that 2 other similar drugs launched and were approved by the FDA over that 15-year time frame or 14-year time frame, including a drug manufactured by Novartis. And so what has happened historically is that drug companies will say, you know what, I'm going to raise the price of my older drug because and make my newer drug less expensive. That way insurers have an incentive to cover the newer drug and move people off the older drug because they're going to save a little money. And then once the older drug goes off patent, everybody's on the new drug. And companies have been using that technique, drug companies have been, to extend the lives of their branded pharmaceutical franchises. And it's perfectly legal. Insurance companies are going along with that, or at least have historically. But that's one of the reasons why you see these older drugs, the prices of these older drugs go up over time. And think about that again. Imagine if Apple said that the iPod from 2001, they were going to charge 2.5 times for that today than they did in 2001. We'd all think they were crazy. If Samsung did that with high-definition televisions, we'd think they were crazy. But this is what happens in the pharmaceutical industry. So this isn't because of greed, I would argue. It's not because of innovation or the need to fund innovation. It's actually because federal policies have distorted the way we pay for and use prescription drugs in such a way that those conventions of, say, the technology industry don't apply to prescription drugs. One thing that's actually the most important thing to point out, I think, is this is not merely a matter of affordability of prescription drugs for people who need them. It's also a fiscal problem. We spend $2 trillion a year in terms of government spending on prescription drugs. And a big part of the reason why is because we subsidize, as many of you know, if not all of you, the cost of health coverage for so many Americans. We subsidize it obviously through the Medicaid and Medicare programs, but also through the tax exclusion for employer-sponsored health insurance, the value of which is just as large as what we spend on Medicaid and almost as large as what we spend on Medicare. So if you include the lost revenue to the federal, state, and local governments from the employer tax exclusion and add that on to what we spend on Medicare, Medicaid, and the ACA exchanges, we're talking about nearly $2 trillion of subsidies for health insurance every year. So is it any surprise that providers of healthcare services, including prescription drug manufacturers, charge a lot for their services, knowing that the consumer is insulated from the price and value of those services and products? This is the CBO's projection of future federal spending, and I've simplified their data into 2 buckets: healthcare and everything else. So the blue bar is defense, bridges to nowhere, unemployment benefits, whatever you like or don't like about the federal budget, and the red is healthcare, except for, of course, interest on the federal debt. So we're never really going to get to 2050 on this chart because China will pull the credit card and we will face a pretty significant financial and economic crisis. And prescription drugs are a part of that problem, and it can't be avoided. So the point I want to make to my Republican friends in this room, I think there has been this unstated assumption, and sometimes explicitly stated assumption, that we shouldn't mess with the way we pay for prescription drugs in America. The way we do it today is perfectly fine. It's a free market capitalist system. It's not. It's not a free market system when a 10-year-old drug costs 2.5 times as much today than it did 15 years ago, when it doesn't actually increase the value to the patient. That's not how free markets work. Free markets work by delivering better products at a lower price with more quality over time. That's what a truly innovative industry does. And we should be holding the pharmaceutical and biotechnology industries to that standard. What are the biggest reasons why we don't have a free market in pharmaceutical drugs spending today? One of the biggest, as I mentioned, is that we don't pay for any of this stuff directly. And that's the biggest driver of innovation in most other sectors, is that consumers want affordable products. They demand affordable products. When the products aren't affordable, they don't buy them. And so companies have an incentive, a huge economic incentive, to deliver those products at a lower price point with more quality. One thing we don't talk about enough is a regulatory mandate within the ACA, which I worry will be a precedent for the broader healthcare system, which is that the ACA actually requires that insurance companies in the ACA exchanges cover branded drugs regardless of whether they're more effective than generic alternatives. For every therapeutic class, for every actually pharmaceutical class, ACA insurance products are required to at least cover one branded drug. Now, there may be cases where that's entirely appropriate, but there may be cases where it's not appropriate, where the generic alternatives are just as good, if not better, for a fraction of the cost. Insurers don't have the option to lower premiums and make those premiums more affordable by rationalizing their formularies where they should. Another problem is that even if insurance companies try to use things like deductibles and copays to incentivize patients to choose generic drugs over more expensive branded alternatives, pharmaceutical companies will often say, hey, we'll have these patient assistance programs where we will cover the copay and deductible, so the patient doesn't have to worry about it. And for the drug company, that's a win-win, because the patient gets on the drug, which makes them far more money than whatever they're paying for the copay assistance. And obviously, it looks good to be able to help people afford drugs that they otherwise wouldn't be able to afford. So it all seems really nice, but the end result is there's a lot of utilization of branded drugs where it's not always obvious that the clinical value is there. Where it is, great, but it isn't always. The second very, very important area is, of course, that it's extremely difficult to develop innovative new drugs. The FDA has gradually layered on more and more requirements to the point where it now costs, according to Tufts University, an average of $2.6 billion to launch a new drug if you incorporate all the times drugs fail in development for every one that succeeds. There's also the fact that, of course, there are patents. So if you develop a new drug and it's innovative, the patent extends, say, let's typically say it's on average, it's about 10 years after the FDA approves your drug. And that's a monopoly. That's okay. That the Constitution provides for that. That's meant to be a reward for innovation. That's a totally appropriate way to restrict competition in the short term. But it does mean that for that period of the patent life, for the monopoly, there is a monopoly, and that can be a barrier to competition, especially because it's otherwise so difficult to develop new drugs. Where the free market is allowed to work in the pharmaceutical industry, it actually works very well. One thing that we don't spend enough time thinking about and talking about is the fact that for all the complaints about the high price of branded prescription drugs, the United States leads the world in the percentage of prescriptions that are actually generic. Because of a visionary law passed in 1984 by Representative Waxman and Senator Hatch, drug companies in the United States, generic drug companies in the United States, have much broader access to the patient pool once a drug goes off patent. So when the statin drugs I was mentioning before, the cholesterol-lowering drugs, went off patent, like Zocor and Lipitor, generic drugs came in and took over that market at a fraction of the cost. It costs less to manufacture most generic drugs than it does to manufacture a bottle of water or a can of Coke. And so that's a major, major driver of value in our system compared to a lot of European countries where the ability of generic companies to substitute their products for older branded drugs is much more restricted by regulation. So today, 90% of all prescriptions in the United States are actually for inexpensive generic drugs. So it is important to understand in context, while we are concerned about the high price of branded drugs, the price of generic drugs is very low, and there's a lot more success in the United States for that issue. And insurance companies are getting smarter about delivering generic drugs to patients by steering patients to cost-effective prescription drugs. That process is going on, as you heard earlier today. So what can we do to improve where we are? As you know, Hillary Clinton has proposed some reforms to drug pricing to tackle this problem. I'm afraid her proposal would actually make the problem worse in a lot of ways. It would further subsidize the insurance coverage of pharmaceuticals in a way that would leave drug companies less accountable for the economic value of their drugs. It would shorten the patent life of pharmaceuticals in a way that would make it harder to develop innovative new drugs. And some of the things like importing drugs from Canada won't really have much of an effect because Canada is 1/10 the size of the United States. And drug companies are much more sophisticated now in restricting inventory to those countries so that you can't import drugs into the United States. So bottom line, even if you could import drugs from Canada, it wouldn't have that much impact on the US market. And importantly, she did nothing on FDA reform, which is one of the principal problems that drives up the cost of health care, and nothing on regulatory reform, which outside of FDA reform is an extremely important problem. So what could we do to actually solve this problem? It's very simple. Let's do more to reduce the barriers to entry for new competitors. Reform the FDA. We have, as you know, in the House, this 21st Century Cures bill. That's a modest step, but a good step to actually remove some of the barriers to competitive entrance in all of these disease areas. We can level the playing field between branded drugs with patents and insurance companies. Today, insurance companies are barred by regulation from banding together to negotiate with drug companies. People talk about Medicare negotiating. Well, what about private insurers? The way drug companies work now is they can say, well, if you don't cover my drug, but this guy does, then you're going to lose all your patients. So insurance companies feel a pressure to cover drugs even when the economic value isn't there. Let companies band together to negotiate for the length of that patent monopoly. You would get a much more economically rational result. And you can do more to allow people to shop for their own health coverage, because that gives health plans more of an incentive to rationalize their drug formulas, and not just with drugs, but with doctors and hospitals too, to deliver that insurance product in a cost-effective way. That will lead to all sorts of downstream effects with plan design innovation like you've heard about today, and better value for patients. If you want to hear more about my thoughts on this, you can download these various documents. And with that, I thank you for your time. Look forward to your questions.